Welcome back, Sports Medicine Project people, to episode 94 of the Sports Medicine Project. And boy, am I excited to bring you this episode, Dr. Keith Baar. This is the one. You know, you record lots of podcasts, you speak to lots of smart people, knowledgeable people, charismatic people, and you learn so much information, and then someone comes along and everything that you thought you knew, or perhaps how you thought something worked, changes. There's a whole new perspective, and we're not just talking, out in lieu. We're talking about things that have research to back it up. We're talking about people doing some pretty crazy things over in some labs over in the US, and this is that episode. This is the one.
Yeah, I've recommended this episode to so many people already, and it hasn't even been released yet.
Yeah.
And I re-listened to this episode and wrote some notes, and I have my whole notes section of my phone is like 3 pages long of just rewriting little snippets and learnings and things that I have really taken away from this podcast. And it's also great because it sort of just builds layers upon what we already know. So it's not saying that what we've been doing is wrong, but it's just saying we could be doing something else on top of that to make to help patients with better outcomes and to get them even better, which I think is really great. Another thought that I had with this podcast episode is, we always talk about how, massage and dry needling is almost like a bit of a band-aid fix and not actually helping the person and really getting them to what they need to be able to do. And this almost sort of takes a bite out of some of the work that we would do, say, with managing tendons, and saying that, in some ways that's kind of what we do. And this is actually trying to, build a whole nother layer on top of that of rehab that can really help people for longer terms and longer outcomes.
What's it taking a bite out of?
I don't know. It's late for me. Does that not make sense?
No. So people that do more manual therapy, this podcast takes a bite out of that.
No, I was sort of more so implying like takes a bite out of Jill and Ebony. And treating donuts, not holes, because we're gonna have to treat holes. We're gonna get all the holes better.
We're treating the whole tendon. Well, Keith is a very, very intelligent person, but he's what's the word when you're able to explain something?
He can articulate things
articulate,
very well.
Yeah. The way he articulates the information is well above definitely where I wish I was. But even, and he mentions that in the podcast, that his research and what they're doing over in the lab is very different, and he talks about that at the very start. But what he's focusing on is different. If he's talking about someone else that might be looking more, say, clinically and looking at pain and function, he's looking at other things like on a tissue physiology level. And we always talk about the difference between, someone can have a weak tendon that's not painful, someone can have a painful tendon that's weak, and all the different combinations you can have. He's talking about treating things on a structural level. And it seems to be so far that they have enough research to at least bring the conversation with some evidence behind it.
The other thing that I've been reflecting on since we recorded this podcast, because we recorded a podcast, just you and I, a couple of weeks ago, talking about trying to understand tendons and how they come about and how they present and everything like that. And I was sort of in some ways sort of like shutting you down when you were trying to get to that sort of physiological level of like that pathophysiological level of understanding tendons. And I was sort of saying, I don't know if we need to be able to have to explain that to patients, but I think even just listening to Keith talk, it makes so much sense as to why we need to understand the cells. It's because you were telling me about it. So
I was trying to say it, and then Keith says, and you can't take your eyes off him.
It's true. It's when you try and help me with an injury, and I don't listen to you, and someone else tells me the same thing, and I listen to them, and vice versa. You do it to me too.
I don't have anything to say at all. The way that this podcast goes, and you'll all feel the same after you get through it. You're like, holy shit, this is crazy.
It's just
this is cool.
Bang, new piece of information. Bang, another new piece of information. Bang, little snippet. Bang, another little snippet. So cool.
Yeah, it's great. And, Kelly and I definitely, we've got to be transparent. We had some questions, very, very few questions, because we knew we were going to speak for a while, but we were trying to keep pace with this new information and then trying to relate it back to how that would help us clinically. And I don't know about you, but I definitely got lost a little bit because he's given me so much information that I'm like, wow, I need to know. So does this mean this, or could this potentially mean this? And I get a little bit warped and just lost for words. It was great, which is awesome to think. I mean, what we always want to do with the podcast is have someone speak about some information like, hey, this is really cool, this happens, but then how can that help us clinically? How can that help us get better patient outcomes, potentially feel more confident, because we're all just trying to get better. Well, we definitely are. So hope you all enjoy it. What would you say your biggest takeaway, the thing that you're been thinking about the most? Because it's been a couple of weeks now since you recorded. We talked a lot of information after it, but what do you think that's kind of stuck with you that you've been thinking about in the clinic?
A lot of the principles just around stress shielding and then stress relaxation, and how we can be implementing Isometrics to try and encourage more of that stress relaxation and try and have an impact on that more degenerate portion of the tendon. And I've just been dishing it out left, right and centre. Everyone gets ISOs now. Yeah. I've been doing ISOs as well.
Yeah, you have been doing it for the time frame though. You've been doing the...
I have. It takes me 10 minutes to get through it for left, right Achilles and hamstring. I've got a few tendons I've got to get on top of those. That's
you're doing lots of ISOs. The one thing that stuck with me is and he talks about this towards the end, where he says, talking about treating the whole donut, not just I never get the saying right.
Yeah, you get it wrong every time.
Why? I don't know. It just doesn't. It makes sense to me to say.
You talk about treating the whole, not the donut.
It's the other way around. Yeah. So when we're talking about just treating the donut, not the whole, and he's talking about treating the whole.
Yes.
The thing that really stuck with me is we all know very, very clearly that the risk of having another tendon injury or the same tendon injury after having it before is higher. If you've had Achilles tendinopathy, your risk of having it again is higher. And one of the reasons that he thinks that could be is we do have this hole, or this degenerative part of the tendon, where the extracellular matrix and the collagen and cross linkages and all these things are happening within there that's different to the outside. That if we're not treating that, that's the risk, or that's the part that's at most risk of flaring up. And because it's been sore before, its threshold for becoming sore and painful again is a lot lower. And potentially if we're able to treat that with this protocol, or with this new kind of, not new therapy, but this new way of thinking about it, potentially that could then mean that our risk of tendon injury in the future is just what it was before we got the tendon injury to start with.
Which is pretty cool.
Yeah, that is pretty cool. That is awesome. And then, we spoke about it a couple of weeks ago. If we can, if you were to purposely get a tendinopathy, and then your other tendon around it would get really strong, but then you would treat the actual hole, and then you'd have even more tendon to be able to generate that force. But it was awesome. I know you guys are going to love it. And I think it goes from basically tendon pathophysiology to what stress shielding to treating the donut and the hole, and then talking about collagen, and then talking about what kind of rehab we need, and also what to do and what not to do with tendinopathy, and also what his research is showing with the structure changes and what's on the future in probably the next 5 to 10 years, which is awesome. Enjoy this episode.
Wait, I've got...
Oh, yeah?
The other thing that I wanted to mention as well to you guys is that we talk about mentors a lot, and I've often talked about one of my main mentors, Dave Renfrew. He has recently come out with a online course, which is awesome. Lots of great content on there that I'm sure everyone that's listening to this podcast could get something out of. The way that he's sort of structured it is there's a lot of videos that are constantly being updated, but then there's also going to be opportunities for live chats and live discussions on there as well. So his online course is called Pain in Practice. So if you're interested in that, head over to his website, maybe. We'll link it in the show notes below, and get stuck into that for a little bit of PD at the end of the year, take you through the Christmas holidays and into the new year. Something out of it. He's a weapon clinician and has a lot of really good practical tips for treating complex patients, really trying to help the person, not just the problem. So check that one out. We'll link it. Blake will link it below, and that's all from me.
Welcome back, Sports Medicine Project listeners, to another episode of the Sports Medicine Project. Now you're listening to myself. I've got my co-host Kelly Kortik on, and we are pretty thrilled and pretty excited to welcome Dr. Keith Baar all the way over in Holland.
Yeah, thank you very much. It's great to be here. This is wonderful.
Mate, thank you so much for coming on. Now, we're just saying off air, like, we are so excited because we've quoted your work for quite a lot of times on the podcast, talking about some of your tendinopathy research, your musculoskeletal research. So it's just awesome to finally be able to obviously see you in person, but hear from you as well.
No, that's wonderful. I look forward to this. It should be good.
Yeah, so we wanted to always, I guess, tell the listeners kind of what you've done over the past, several years, but you've been quite a busy person now. We're trying to have it in somewhat of an elevated pitch, and please correct me if anything I need to add in. But currently, at the moment, you're a professor at UC Davis, and you do a lot of research around tendons, musculoskeletal health, a lot more nutrition and tendons and that kind of thing. And you're the lead of the Functional Molecular Biology Lab at UC Davis, is that right?
That is correct, yeah.
Yeah, so I put this quote into here, and to me, this sounds like a dream. I could imagine nothing better than this. The first line of kind of what that lab is about is to understand the molecular determinants of musculoskeletal development and the role of exercise improving health and performance. To achieve this, you work on muscle, tendon, and ligament from 2- and 3-dimensional tissue culture, in vivo, wild type, and genetically modified animals and humans. Like, that's awesome. That's so cool.
Yeah, it is something that I have built over the last 15 years with some incredible trainees, and been able to really get to a point where we can do things that nobody else in the world can do. So we can take cells that we isolate from people after they've ruptured their ACL, and we can isolate those cells, and we can engineer human ligaments that are functionally very similar to kind of embryonic to early neonatal human ligaments. And then we can load them, and we can put in different nutritional aspects, or we could add different drugs to them, and we can make fundamental discoveries that we can then quickly translate up into a rodent model, where we can then look to see how it works in rodents, and then we can move it up into people, and we can test it in people. So we've got this ability to go from very basic discovery work all the way up into people in a very short period of time.
And would you say, like, that's the tendon research, because there's lots of conflicting studies, talking about structure and function and pain and what matters and what doesn't. Like, is that the big limiter at the moment to the research progressing, where it's very hard to take, biopsies and test these tendons the way that we probably need to in someone that's alive, and ethics and things like that?
Well, absolutely. So really, we don't get many human tendons that we can manipulate. The reason that I'm doing a sabbatical in Holland is because what we're doing here is we are taking tendons that we're getting from people who are undergoing ACL reconstruction. So they're getting their ACL reconstructed using a hamstring autograft. So what we're doing is we're going in and we are doing different dietary manipulations. And then when they go in to get their hamstring autograft, they take it out, they build the new ACL. And what they always do is they're always going to take off a little bit of the tissue. And that human tendon tissue, we can now look at using deuterated water to see what kind of protein turnover there was in that. Do we see differences in protein turnover in the proximal versus distal? Do we see the core of the tendon doesn't turn over as much as the outside? We can ask all of these questions that are very difficult to ask in any other way. But if you think about it, Michael Kerr is the only real person who's taking human tendon biopsies. And even there, they're starting to slow down because there are some issues with taking the human biopsies from the patellar tendon. And there, you're only getting the very outside. And what we're learning is that the metabolism and the structure and the function of of a tendon is potentially different in the inside versus the outside. It's potentially different for how quickly the proteins turn over inside to outside. So it's not necessarily giving us something that's indicative of the whole tissue. And so this is one of the few times where you can actually get a whole human tendon. And even though the hamstring tendon isn't like an Achilles, where you've got a tendon that inserts on a bone and then it comes up and there's this really nice tendinous process and then it has a myotendinous junction, The hamstring tendon is much more like an aponeurosis, where the muscle is coming in at an angle and it has a very short attachment. So it's not exactly going to be indicative of every tendon in the body, but this is one of the rare times where you can actually get human tendons to do this kind of work. And so it is extraordinarily difficult to get models that allow us to see what's happening in humans.
How much do you
And
think
that's
this
why,
is?
go ahead.
Sorry, I was gonna just
No,
ask. You go.
I was just going to say that that's why we've developed the animal models and we have the human the human engineered tissues, because there we get the whole tissue. We can do all of these manipulations and we can study what happens. Then we can try and infer what would happen in the human. When we do that, then what we can do is we can build out situations where, without having to take out the tendon, how can we test to see whether that's actually really what's happening?
How much do you think this is going to change what we know and how we treat tendons? Some of this newer work that you're doing that is quite different to how a lot of the rest of the world is understanding tendons and able to study tendons.
Yeah, I think hopefully it will change things pretty substantially, because if we look at this, if we look at where we're talking here, so what's standard of care for, oh, you've twisted your ankle pretty severely, you've got pain, standard of care for you guys. Well, sorry?
Like,
what would
Settle
standard
down
of
the
care be?
swelling and then
pain modulating, then load it.
Yeah.
Or movement is
Okay.
medicine, load it as much as you can to what's
So
manageable.
that's very different than what you would see most places, which would be to put it in a boot, to allow the process to kind of go back and to kind of calm down, to do the rest, ice, compress, all of that stuff. And that, putting it into a boot, immobilizing the ankle or immobilizing the joint and taking the weight off of it. The reason that you guys load it now is because that doesn't work. That, putting it into a boot, the first immobilizers were discovered in, when people were looking in Egypt, and they were discovering that people were showing immobilizers from 4,500 years ago, that, oh yeah, they immobilized the ankle. I don't think there's anything in medicine that we're still using 4,500 years later other than boots and casts and all of these things. And there might be a place, if there's an issue with the bone, where you have to externally fixate it. But if you don't have to do that, we've got data that's unpublished where we immobilize the leg in a rat, we lose 20% of the collagen within the tendon within 3 days.
Wow.
It's very similar to what the lab here does, where they immobilize the human knee, and they lose about, I think it's about 0.7% of muscle mass per day. So that over a 3 to 4 day period, you're losing about 2.5% of your quad muscle mass. And it would take you about 8 weeks to recover that. So what you lose in a day, it takes you a week to recover. So why do we then say, oh, you know what, you've got soreness, let's put you into something that's going to immobilize you? And so hopefully that component is going to start changing. And it sounds like it is in Australia more than it is in, say, the United States. But then what we have to do is we have to say, let's look at what kind of load that we're doing. And I think that that's going to be a really important component of what the next stuff that's coming out of our laboratory is looking at. And that's comparing different types of load to see what the different types of load have as far as their ability to either have a positive effect on the structure of the tendon and the material of the tendon, or have a negative effect on the structure and material of the tendon.
And that's what we've spoken about so much. I mean, the current theories, and we literally did an episode a couple of weeks ago talking about like the continuum model of tendinopathy and the degenerative part, and not focusing too much on that because you can't really change it. You don't need to change it for someone to get better, and that kind of theory. But before we get into that, would you be able to just briefly touch on the I guess how you think a tendinopathy occurs, or what we kind of understand from someone with a healthy tendon in theory, whether that means on imaging, not on imaging, and kind of how that leads to, I guess it's just so many questions coming to mind, but like how that leads to tendinopathy, because you can have tendinopathy without pain. You can have healthy tendon and pain-free tendon and weak tendons, but you can have, lots of different things. So kind of what's your
Right.
understanding of how that ends up at a tendinopathy?
Yeah, so I think it's important to start with the common definition of tendinopathy, which is just that it's just pain in a tendon.
Mm.
That's how we look at it, is pain in a tendon. And so in human tendinopathy, we say that it's a painful tendon. Doesn't mean that there aren't tendinopathic tendons that aren't painful, because we talk to basketball players, and basketball players, oh yeah, my knees are fine. You take an image of it and you see a big ass hole in the middle of the tendon, and you're like, oh, really? Are your knees that fine? So, and Jill Cook's done some beautiful work down in Australia with the basketball league there. And she says that she can see, I think it was over 75% of basketball players have imaging-based tendinopathic, markers within the tendon. So we define tendinopathy as any problem within the tendon, painful tendon. There's tendinitis. The tendinitis is an acute inflammatory response. And inflammation within tendon is highly, it's highly contentious. The idea of this tendinitis, and then there's tendinosis. Tendinosis, signs of inflammation. Tendinitis has its signs of inflammation. So what we see and what we think is happening is that you're going to go in and you're going to do too much. Somebody is going to overdo it with their physical training. They're going to go at a higher intensity or a higher volume than they have been in the past. And one of the things that we know about tendons is that tendons at the enthesis, so Benjamin and Rouse showed beautiful enthesis structures. And what an enthesis is, the bone tendon or the bone ligament interface. And at the enthesis, there's always a fat pad there. And that fat pad is there to lubricate, to provide vascular, supply, to do all of these wonderful things. But if you're going to go out and you're going to do a huge amount of high velocity loading or high jerk loading, what's going to happen is that fat pad is going to get compressed and compressed and compressed, and that's going to help the tendon not get injured. But over time, that fat pad is going to get damaged. It's a highly vascular tissue. It's going to start producing cytokines. And we've got a huge paper that's coming out now from a PhD student who's been working on tendinitis for a long time. And what he does is he can put in different cytokines, so different inflammatory cell proteins that the inflammatory cells produce. And as he does this, as he increases the amount, you get a dose-dependent decrease in collagen within the tendon. You get a dose-dependent decrease in the mechanics of the tendon. If you think about this, it makes sense. If you have damage to the tendon, what you need to be able to do is you need to be able to get load through that to have it fix. If the tendon is super stiff, the tendon is going to kind of protect the injured area. So if you have cytokines that are making the tendon less stiff, it's possible that that's something that evolutionarily developed to try and increase the uniformity of the load through the injured tendon and to get uniform load through the tendon. So we think that the inflammation is actually super important and super good and positive for it. So we don't do things to try and block the inflammation, because that inflammation we think is really important. There's two molecular pathways that inflammation can go through. So one of them is NF-kappa B, and that's a very famous one. And another one is this JAK-STAT pathway. And both of them are activated by these inflammatory markers. When we go in and we inhibit NF-kappa B, which is the dominant inflammatory pathway within our cells, we actually make our ligaments horrible. We make our engineered ligaments to the point where they're useless. They have no tensile strength. They have no collagen content. Mm-hmm. What that tells us is that inflammatory component, that NF-kappa B, is absolutely essential to the formation of new collagen, to the production of a healthy and strong tendon or ligament. What we're finding is that the other pathway, this JAK-STAT pathway, is something that maybe we can manipulate. And when we manipulate it, we can improve tendon function. So we just had a paper come out where when we used a JAK1 inhibitor, What happened is our engineered ligaments got bigger and they got stronger. And now the paper that's in review right now, we use the JAK1 inhibitor together with cytokines. And what we can do is reverse the tendinopathy or the tendinitis type of phenotype. We can make it so that the tendon isn't as stretchy and it has more collagen. So what it's telling us is that there's probably an acute inflammatory response. We think if you talk to people and they say, I've got an acute tendinitis, and say it's in the knee. The interesting thing is an acute tendinitis in the patellar tendon tends to be towards the patella side, or sorry, towards the tibial side. A chronic patellar tendinitis tends to be toward the patellar side. The same thing is true with the Achilles. If you do an acute overload of the Achilles, you tend to get something towards the heel. More chronic stuff, it's up a little bit higher. What's towards the distal end is that enthesis, is that fat pad. So it's possible that what we're feeling in those acute inflammatory tendinitis, that is entirely possible that it's the inflammatory response from that fat pad that is causing a local problem within the tendon. And that if we can use load to pump out the inflammation and to pump out some of the swelling, we can actually use that load. And now that the tendon is a little bit less stiff at that area, I can actually fix it because that's what the whole inflammatory process is potentially there for. So what we're trying to do is we're trying to flip on its head what inflammation is in the tendon and what its role is in tendinitis or tendinopathy.
Wow.
That's such a good explanation of
Yeah.
all of that.
Kelly and I have spoken about it on the episode plenty of times, but not in that detail at all.
I remember like a few weeks ago, we were talking about the pathophysiology of bones versus tendons. And we were both sort of saying like bones is just so clear cut in some ways. Like it's really easy to explain. It's very logical. It makes a lot of sense. Whereas trying to really understand tendinopathy is harder. Like it's a lot more complex in a lot of ways than understanding the pathophysiology of a bone stress injury. So thank you for going into depths with that. I think that was useful.
And the reason that all of this becomes important is that we don't think that, yes, the acute overload is what's going to cause the initiation of the tendinopathy. But what actually causes the mature tendinopathy isn't that acute response. It's the fact that we don't get load through the tissue. We don't get load through the injured area, the little area that maybe has a little bit of damage. And if we don't get load through there, we're going to get stress shielding. And, I always point to Hayashi's work from Japan. He did these beautiful studies in rabbits where all he did was he took a perfectly healthy patellar tendon. He just put a wire through the patella to the tibial plateau, unloaded the patellar tendon. And within 2 weeks, what happened was the tendon became highly cellular, the collagen fibrils became smaller, and the directional orientation of the collagen became random. All three of those things are exactly what we consider a scar. A scar is non-directional collagen with more cells and smaller collagen fibrils. He produced a scar just by unloading it. We've done the same thing now by unloading or by immobilizing the ankle of a rat. So what that's telling us is that the initiation component is some sort of overload trauma. And then we think that the inflammation is really important to try and decrease the stiffness of the tissue so that you can get load through and fix that part. But if we do lots of things to keep inflammation low and we prevent that decrease in stiffness, now what we're going to have is we're not getting load through the injured part. And now that's going to become a more permanent or more established problem because we're going to get stress shielding. The part of the tendon that's not loaded is now going to look like Hayashi's stress shielded patellar tendon. It's going to become more cellular. It's going to have non-directional collagen, and the collagen's not going to be as big. And so if we look and we say, where do we see people get these long-term tendinopathies? Does it happen in really young kids? No, because they don't have stiff tendons. Does it happen in more mature? Does it happen more in men than women? A lot of things where we see more stiffness we see more tendinopathy. It happens more in old people because they have stiffer tendons. It happens more in men because they have stiffer tendons. All of these components are going to then say, look, if I have a really stiff tendon, I am going to be more likely to have potential tendinopathy because I'm going to stress shield better because I have a stronger tendon.
Can you explain? I think stress shielding is a term that's been thrown around maybe a little bit more recently in Australia, but I don't think it's something that a lot of Australian physios, from my understanding, have a really good grasp on. Can you elaborate on what you mean by that?
Sure. It's a simple concept. So if I have if I have a little piece of string and I pull on it, you know that it's going to break pretty easily. If I now have that same little piece of string and I put right beside it a wire that's super strong, if I pull on it now, that little weak piece of string is never going to break. And the reason it's never going to break is because it's never going to feel the load. Because if I'm pulling and one thing is really stiff and one thing is really compliant, as I go to pull both of them together, all the load goes through the stiff thing and none of the load goes through the compliant thing. It is most common in bone because bone orthopedic surgeons know this for bone. If you go to the bone literature, you put in stress shielding, there are thousands upon thousands of articles. And the reason is that what do we do with old bones? Let's go ahead and put in a piece of metal into the hip. So we're going to do a hip replacement. So what happens? I'm going to take a piece of titanium and I'm going to stick it in the middle of a femur and I'm going to put it in. There's going to be a ball and all of that. Everybody knows within about 10 years you have to replace the hip. And the reason you have to replace the hip is nothing to do with the metal and the joint actually having any problems. It's that now the bone channel where you put that piece of metal, all the bone around that metal has died. And the reason it's died is because the metal is so much stiffer than the native bone that whenever load goes through that, it goes only through the prosthetic. It doesn't go through the native bone. And so if you don't use the native bone, it's going to go away. It's going to atrophy. And so the result is that soon the hip starts moving around within the femur. Now you have to replace that hip that you've got within about 10 years. That's the most common place that people see stress shielding, is that when you have something really stiff like a prosthetic, it prevents load going through the native tissue. We're now seeing it a lot because orthopedic surgeons are thinking, okay, I want this to be strong and I want people to be able to load the next day and I want them to do all of these things. So instead of using a fast resorbable suture, I'm going to put in reinforced suture. I'm going to put in Arthrex. I'm going to put in something that's really strong. And then the person can load right away. The problem is that now suture is going to stress shield the tendon. So now I can't fix the tendon because every time I try and load the tendon, it all goes through whatever fixation I've used. And then, yes, you get back, you can load early, but then at a certain point, that material that you've put in there is going to fail. And as it fails, our native tissue hasn't recovered, hasn't regenerated to the point where it can actually take on the load. And so you get a re-rupture really quickly.
So if that's happening, and let's say for the tendon, you've got let's say in quotation marks, the hole in the tendon or degenerative part, the tendon around it, what we've seen in the research is that the part around there that, let's say, has been loaded, that other part's been protected, the part around it is able to basically pick up the slack, become stronger, become resilient, and people are still able to go on and achieve and live meaningful lives and have less pain and function better. What do we see as the benefit of being able to manage that kind of hole? I guess that's kind of where we're getting to with the stress relaxation. If we do isometrics, and I've read a couple of your studies and listened to podcasts where you talk about controlling for time under tension and reps where you can stress relax and then actually start to load that area. What is the benefit? Just we can have basically treat the donut, not just the surrounding part.
Yeah, so basically the idea behind treat the donut, not the hole, is that we can't fix the tissue that's been damaged. And our research says that that's not true.
I'm so excited to hear what you have to say on this.
Because basically the whole always happens in a central core. And the reason that you get a hole within the central core is that when you stress shield, the load goes around the tissue, the injured area. When you've got an injury in the center of a tendon, and this is very common in horses, for example, horses that have very long, big tendons, they get what are called central core tendinopathies. And the reason that happens is the load goes around the injured area. When the injury is in the center, because the tendon is isovolumetric, which means that as I pull it, as it lengthens, it has to get skinnier. So now if I have two bits of healthy tendon on either side of an area that's injured, what's going to happen is as I pull on them, they're going to straighten out and they're actually going to compress the injured area. And that compression of that injured area is going to cause compression, which turns the cells within the compressed area into cartilage. And so you're going to get more big proteoglycans. And those big proteoglycans, what do? They suck water in. And that's what gives you the hole. That's what gives you this echo area, this hypoechotic area of you've got a hole within your tendon. Now, people say, okay, let's strengthen the donut. That's fine. But at a certain point, it's not sufficient. And we've had, I did a case study with a basketball player where they had a central core patellar tendinopathy. We did very specific loading to try and get load through that central area. We were able to fill it in. One of his teammates actually wasn't able to do the loading because of other commitments, and he, did classic basketball training, and eventually he ruptured his patellar tendon. When the doctor went in there and to fix the patellar tendon, he said that the whole core of that patellar tendon would become necrotic. So it was green and black. The tissue in there.
What's actually in there? Like what's happening with the collagen and like what structures, matrix and things like that in the area that you typically see?
So in that area where there's the hole, what it is, it's cartilage.
Yeah.
And that's why it only happens in the center. It only happens in the center because it has to have compression. And so when you have a circle of strong tissue around an injured area, as it gets stretched, you get compression on the injured area. As you get compression, I can do this experimentally. We've got our engineered ligaments. We do this. We can set them up so I stretch them longitudinally, so in tension, or I can do the exact same amount of stretch, but I stretch it in a way that part of the tendon gets compressed. If I look at the gene expression on the part of the tendon that gets compressed, it shows cartilage markers. When we did this experimentally in a patellar tendon model of the rat, where we did isometric holds and we compared that to time under tension matched dynamic loads, what we found was that the isometric holds increased markers of tendon, so scleraxis and collagen 1, and the dynamic actually increased collagen 2 within the scarred area. Again, if I take, tendons, cartilage, bone, they come from one precursor cell, a SOX9 positive cell. So this is one transcription factor that makes all of these different things that become our connective tissues. The difference is that once I get a tendon versus a cartilage, what I'm doing is, one, I'm loading in compression, one, I'm loading in tension. By loading in tension, I'm going to get a tendon. By loading in compression, I'm going to get cartilage, even though they start as the same cell. So when I have a tendon and it's got some weak area, and I'm not getting tensional load through that because I'm not letting load go through there, I'm not getting a signal for it to be a tendon. And if it's a central core, now what is going to happen is it's going to get compressed. And now what I have is I have a stimulus to make it into cartilage without a stimulus to make it into tendon. And so I can take the same cells and change their fate based on what type of load I get through.
Do you see that as being a problem, having cartilage in the core of the tendon, or would that not be or is that not a normal response to loading? No?
Not normal at all.
Okay.
So what I'm taking from that is, because what we would think of as normal tendinopathy practice is as soon as you can, you want to get someone loading the tendon how tendons are meant to be loaded, which is dynamically fast rates of movement. Like you're getting them to that point where they can hop and jump and use it, guided by pain and function. But what you're saying is almost by doing that, you're going to be increasing that compressive load in that area sooner, and then potentially making it, because obviously it gets to a point where you're not going to be able to reverse anything like that. You're getting it to a point where you will just fill that hole with cartilage markers.
Yeah, you're filling the hole with cartilage. But remember, so now what we've got is we've got this situation where you're doing a lot of dynamic load. Okay, so you're getting compression on that bit. It's totally fine, because now for me, what I want to do is I want to get tensional load through there in order to fix that. If you're going to go out and you're going to play basketball, you're going to jump, you're going to practice, you're going to, like in my NBA basketball player case study, he played 50 games in the NBA, practiced daily. He did all of his gym work. Didn't change what he was doing, so he had tons and tons of plyometric load. No problem there, because when he's doing that, he's not getting the signal that I want him to get through the tissue. And so now all I have to do is take 5 to 10 minutes to get the load that I want through there. And now the cells are going to get the signal that I want them to get. You can still do all of the rest of your loading, but when you're doing that, because it's going around the cells that we're concerned with, that injured cells, the cells within the injured region of the tendon, they're not getting the load that we want them to get. So now when I load them using these short, approximately 10 minutes of load, what I'm getting is I'm getting the minimal effective dose of loading through the cells, and that's going to give them the signal that they need in order to start directionally orienting their collagen, and in order to start them maturing again. Because normally what we would want to have happen is we'd want to have them regenerate the tissue. The way that most tissues regenerate is by recapitulating developmental processes. When we do that in a tendon, we don't get full recapitulation of development. And the reason is we don't get the load component that we need in order to get the directional orientation. Once we get that directionally oriented load, and it only has to be 10 minutes a day, now I've got the signal that I need. I'm going to start getting load and that directional orientation. If I continue to do that, I am going to start fixing the tissue. If I have a period where I just do that loading, yes, it's going to progress faster. And then I can move back to the dynamic loading while maintaining the signal for that tensional component.
So it's almost, if you're loading it dynamically, you're treating around there. And then if you're loading it isometrically and doing that, the minimum effective dosage, which we'll talk about, is at roughly 10 minutes, you will be training inside. And it doesn't take much from a minimum effective dose to basically elicit a response for those tendon producing cells. And
absolutely.
Yeah, wow. Could you give us like an example of potentially like what a week would look like? Because imagine it like a runner or someone that's doing a lot of jumping and plyometrics. What would a week look like? Because in your studies, at knee flexion isometrics, is that right? Sorry, knee extension isometrics.
Knee extension isometrics. So either isometric squat or isometric knee extension. So those two, you're looking at, when we've done it in the model, in the animal model, it's just 4 times 30 seconds with 2 minutes of rest. It looks like maybe if we extend it out and even make them longer, that there's a bigger benefit, because again, you're going to get greater stress relaxation. You're going to get greater load through that area. So we're now looking to, we're looking to have those isometrics maybe last even a little bit longer if possible. But 30 seconds is a great, starting point. If you've got that 4 by 30 seconds with 2 minutes rest, that's 8 minutes of load. And what that does is the reason that we do a 30-second isometric is because when I apply load into a tendon, when I give the initial pull on the tendon, I'm going to get a lot of I'm going to get a lot of stiffness within the tendon. If I then hold it at that exact same length, now what's going to happen is I'm going to get an exponential decay in the stiffness within that tissue. We all know it. We've all done, say a wall sit, where over a minute or two, your legs start to shake and you have all of it because the tendons are starting to relax. Your muscles have to continue to contract in order to maintain that position that you're in. That decrease in stiffness within the tendon, the reason that we don't get load through the injured part is it's a lower stiffness because it's not directionally oriented compared to the rest of the tissue. If the rest of the tissue is undergoing this exponential decrease in stiffness, it's going to get to a point where, oh, now it's less stiff than the scar. And now the scar is going to have to take on the tensional load. And as the scar takes on the tensional load, now I'm going to get a signal through those cells that those cells now know, okay, I need to produce force in this direction. And we've got data now where we take our engineered ligaments and we do the exact same thing we did in the rats, dynamic load or isometric load. When we do the isometric load, and we do that over a 6-day period where we're doing 10 minutes of isometric load every 6 hours, they get significantly stronger. When we do the dynamic load, they get a little bit more collagen, but what they don't do is they don't get a lot stronger. And when we've now used this technique called digital scanning calorimetry to kind of get an idea as to what the collagen matrix looks like, the enthalpy or the amount of energy it takes to melt the matrix is going up as we load it, specifically when we do the isometric load. So what that's telling us is that this isometric load is changing the basic properties of the collagen matrix. So it's making there so that there's a greater fibril density, that the collagen fibrils themselves are getting bigger. And and we're also getting more cross-linking within the collagen. So all of these things are happening when we get this isometric load, where we don't see the same response when we do the dynamic load.
Is the length of time the main component that's important, or could you increase the intensity or the effort by adding like a plate to their lap or making them do it on one leg and holding it only for like 10 or 15 seconds? Like, what's the main component of that that's important?
Yeah. No, that's a super important question. And really a lot of it is down to how strong is the donut? Because if you've got a lot of historical loading on a tendon that's had tendinopathy, you've developed a much stronger stress shielding. So if you have more stress shielding, what we're going to do is we're going to bend your joint more. We're going to load it at a higher amount, and we're going to hold it for longer. Because what we need to do is we need to get more strain. I can do that by bending. So if I have a problem with my elbow, I can start maybe with something where I'm bent, but if I really have an issue now, if I bend it more, now my tendon is already starting from a lengthened position. Now, if I go at a heavier weight, now the load is, so when I go up and then I'm gonna go down through this exponential decay, that is now going to give me a greater drop in my exponential decay. And if I hold it for longer, I'm going to get further along that decay, so I'm going to get lower stiffness in the healthy part. All of those things are things that we would do if we have somebody who's got a really mature scar, really mature tendinopathy, because they've had years or especially if you've got people who are kind of the classic runners who have run every day of their life for the last 20 years. They're just stubborn as all hell. You can tell by how they move that they're just in pain when they run, but they're going to do it no matter what. Those people have made so many adaptations within their tissues that now I'm probably going to need a greater joint angle. I'm probably going to need more load, and I might need to hold it for longer in order to get that stress relaxation to the point where I can get load through the scar and where I can fix that tissue.
Yeah, that was my next question is, does this have to sort of be implemented in the earlier stage of a tendinopathy, or can this be effective in someone who's got, a very calcific tendon, later down the track?
Absolutely. You can do it in both. You don't need much of a stimulus. So when we do it with kids, like my daughter is a big soccer player, her friends would always get tendinopathies. All we'd have them do is 20-second holds and just body weight, and within a week, totally fine. But as you get older and as you get more mature, adaptations to to stress shield the injury, Now what you're going to need is you're going to need greater load, or you're going to need greater time under tension in order to get that amount of stress relaxation, to get that really substantial stress shielding tendon to relax enough so I can get load through the injury.
And what are you seeing timeframes for someone doing this? Like, have you done any research to look into, 3 months, 6 months, a year until you're seeing what would you see, a resolution where you've got normal non-degenerative changes within that whole part if you've imaged it prior and then imaged it 12 months later? Like, what are you seeing on the time
Yeah,
frames?
so in the basketball example, we have MRI from pre and 12 months after. Completely eliminated the hole within the patellar tendon after 12 months. But that's not indicative of what's actually happening. We have better data that comes actually from a New Zealander who was a big track and field athlete. He had bilateral patellar tendinopathy. Ultrasound you can see end of the patella, you can see a hole in the middle of the patellar tendon, and you can see a very, very weak and very, very minimal patellar tendon on ultrasound. The reason I like this example is 50 days later, after doing 5 times 30-second isometric holds, just doing an overcoming isometric leg extension, that hole is almost completely gone. The patellar tendon thickness and the striation of the patellar tendon is much, much greater. And literally, yeah, he was pain-free within a week, but that hole was completely gone within 50 days.
Wow.
So that's the kind of turnover rate that you can get. And that's a international level athlete who had, he had to stop training because of the pain within the knee, but he's able to get back to training, and he's able to get back to training at a high level very quickly, because basically this type of loading, especially when you're doing it at a heavy weight and at a more extreme joint angle, you're going to get more strain, you're going to get more stress relaxation within the healthy part, you're going to get more load through the central, in that case the central core, and that's going to help fix the tissue.
Is there any data, like once this has happened, let's say post 50 days of doing these isometric contractions, is there any data on the change in function? Like, is someone stronger, or has anything changed in that way? And then also, after that's happened, if you then just continue to load the tendon dynamically, do you see the tendon working as one cohesive unit again, and you don't actually need to continue doing the isometrics? I apologize, there's a lot of what ifs, but it's really interesting.
Yeah. So basically what we'll do is we will still do, say, some maintenance-based isos, but there's not really a need to do them continuously or to do them as a primary thing. We go back to the dynamic load. Maybe at the end of every practice or training session, we're going to do a single isometric just to get signal through there, make sure that we prevent this from happening again. So there's lots of, and then there's performance-wise, absolutely. So one of the interesting things is that when we originally came up with kind of this 10-minute loading, that the load, if you have healthy tendons, the load that you put through the tendon isn't really important. It's the time under, it's this 10-minute component, this minimal effective dose. One of the interesting groups that picked it up was there's a couple of brothers who are professional climbers up in Sweden, and they picked it up, and these are the Abramson brothers, and they basically came up with a program where you would do these hangs. So he would just use a hang board, and he would do a no hang, where he would just put his weight on his fingers. And I don't know if you know climbers, but they all have really bad hand tendons, and they talk about tweakiness, and they all talk about this. So now this is what's lovingly called the Abrahangs. So basically you do this no hang protocol, 10 minutes. They did a 30-second, a 10-minute version of this where they do a bunch of 10 to 20-second holds. And he did a YouTube video on it, and basically his performance, he went up something like 600% on his max hang. So how long what kind of weight he could hold for 5 seconds on a 20-millimeter edge. The YouTube video has been seen almost 1 million times, and it's become extraordinarily popular because what people find is it increases their strength and it decreases the injuries within the tendons and the pulleys in the hand. So again, you can see that, yes, there's a strength component to it, a performance component to it. Absolutely. He was able to, for the first time, do one hang, left-handed one hang hangs that he'd never been able to do before. All of these types of things just from doing some simple tendon-oriented loading that were really just, the idea was that you load the tendon differently than you're going to load skeletal muscle or you're going to load the heart.
Wow. So there you go.
So in regards to like prevention, I know that that's something that's always very tricky to study, but has any of your work looked into doing some of these isometrics in a way of preventing, say, like a patella tendinopathy in a basketball or Achilles tendinopathy in a runner, for example?
Or do you have to have like the degenerative part first?
Once they've,
Yeah, you don't have to have the injury first. So what we do, and again, a lot of this stuff has just been case studies so far. We're trying to use, so we're going back with Emil Abrahamson to try and go and find all of these climbers who have done his climbing protocol to say, okay, what happened to your pain levels? What happened to your performance? And can we go through and do these large clinical studies on these groups that have really started to implement this? One of the groups that we did the kind of isometric prevention holds in was an American football team. And so they approached us because the year before they had 26 non-contact muscle pulls. So all their fastest players were getting all of these muscle pulls. And so we had come, we said, look, one of the reasons is you're getting this issue where as they just are doing lots of fast work, they're doing lots of plyometric load, they're getting this plyometric load through the tissue, the tendon is becoming stiffer, and the muscle, because you're not lifting heavy weight, isn't as strong. And so the tendon has become stiffer, then the muscle is strong, and so now we're getting muscle pulls. And so all we did for them was we did a series of 30-second isometrics at the end of all of their practice in games, and they went the next year to 3 non-contact muscle pulls. So you can see prevention. There's always lots of other things because those aren't controlled studies. They're not, but now we're trying to go back and we're trying to systematically, go in and say, okay, what you're going to do is you're going to volunteer for this study. We're going to put you into one of 3 groups. Now we're going to look at your injury rate. We're going to look at your performance. We're going to look at all of these things to see whether we can chart, as you do these workouts, do we see clinical benefit that we can statistically say, look, there's a clinical benefit there. So far, it's just working within groups and teams. We're doing the same thing with a couple of football clubs that have implemented this with their developmental teams, and and they've seen a big decrease in injury rate, a big increase in strength just by doing more isometric based holds. Again, we're trying to increase the number of individuals and get clinical level data that is reliable and we can actually go and make conclusions about.
And for the clinical translation, for people that are seeing tendinopathy, which you would have to think is one of the most common things to present, especially over here in Australia, into the clinic, how are people able to identify, like if they're just saying, I've had a painful tendon for 3 or 4 months, is it just safe to assume you probably have some level of, not tendinopathy, but some level of change within your tendon, and it may be potentially best for them to implement it? Or should people be getting ultrasounds, or currently where's the practice at of trying to see what's changing and any of this is actually happening?
So you can do imaging, ultrasound-based imaging, MRI-based imaging that can be helpful, but you can get painful tendon without anything on ultrasound or MRI. One of the big things that I put into my research grants is, look, this is an issue that is extraordinarily complex and we need new solutions for. And the best example of why we need new solutions for this is that 95% of physical therapists have tendinopathies. If you have a more educated group on what you're supposed to do, it's going to be physical therapists. And if what we're doing right now is going to be effective, 95% of them shouldn't have tendinopathy. The reason that they have tendinopathy is because they're doing all of these incredibly, strenuous things with hands and with elbow, and they're very active people in the first place. But if it were simple, they would all just say, "Oh, I've got this. Oh yeah, ISO here and ISO there." They should be able to deal with it better than anybody else. And yet 95% of and that's a statistic that we get from a large scale physical therapy epidemiological survey that was done. And so what that's telling us is that this is a major problem, that if I just tweak my elbow because I went out and played, it was a beautiful day, I went out and played tennis, and now I've got some elbow pain, I'm going to do isometric loads right away. If I do what I've done many times, which is you go out, and even out until I was 50, I was still playing intramurals with my lab group, and I would twist an ankle. I twist the ankle. Oh yeah. Immediately that night, I'm doing full mobility. I'm doing isometric holds. I'm going up to the point of pain and I'm holding it there. I'm doing loading that is designed to treat tendinopathy right away. I'm not going to wait until some later point in time. I'm not going to immobilize it. I am going to use that load in order to maximize my immediate response to that. I am going to use the inflammatory response to help me get load through that injured part so I can fix it better. I am going to be able to do those things because that is just a tendon injury has the capacity to develop into tendinopathy very easily. And if you look at cells within a tendinopathic tendon, even if there's no inflammation there, they've already been primed for reinitiation of an inflammatory response. So they already have epigenetic signs that they've had inflammation. So what that means is that there are epigenetic marks on their DNA that says inflammation has been here in the past. And if we have another inflammatory stimulus, they're going to respond much more dramatically than if they'd never seen an inflammatory response before. So what does that mean? That means that every little tiny tweak or twinge or anything, I am going to use my isometric loads. I'm going to use my tendon specific loading to try and get load through it as quickly as I can.
And so when you were speaking about the cells being primed, is that like the reactive or degenerative part of tendinopathy?
Yeah, so it's basically the same way if you're a pregnant mother, the first time everything goes slowly, the second time your body already knows what to do. It's got epigenetic changes, so you develop all of these, and it's like you're a month further along in your pregnancy because everything happens more quickly. Same thing is happening because there's been an inflammatory response in the tendon. The cells within the tendon have been marked. They've been changed epigenetically by that initial inflammatory response. So now when there's another stimulus that causes inflammation, now they're going to respond much stronger. And so that's work out of WashU. Actually, now he's at Columbia. There's a professor there who does amazing work. And he's basically shown that component of epigenetic changing of the tendon cells induced by inflammation has marked them to be more responsive or more reactive later.
And do you think that's potentially one of the reasons why that the last study I read, it was something like that for the 5 years after someone has been either, I can't remember if it was discharged or officially diagnosed, but 5 years post, and this is the Achilles tendon, they still report pain and impairments to their function. Do you think that that's a potential contributor to that, because we're loading them dynamically and we're seeing these changes and then they're never fully really, I guess, recovering to a degree?
Yeah, so that's why we try and fill the holes.
Yeah.
Because if you don't fill the holes, there's always going to be pain. And all that's going to happen is that, yeah, you're going to train for a while, you're going to be developing the other side, but then you're going to take a few days off, and now that's going to be a little bit weaker, and now the tendinopathy is going to come back more strongly because basically you've never fixed the tissue. So really what you're looking to do is if you have to structurally repair the tendon. Until you structurally repair the tendon, what you're doing is you're masking symptoms. It's like if you have a cold and you take cold medicine, you feel better. Oh yeah, I don't have a cold anymore. Well, no, you still have the cold. All you've done is you've suppressed your body's ability to fight the cold, so you don't have any of your symptoms. Same kind of thing is true. You're not treating the tendinopathy, you're treating the symptoms. You're not treating the cold, you're treating the symptoms. So what happens is when you stop treating the symptoms, the cold comes back or the tendinopathy comes back. And until you actually let your body or you structurally do something to treat the actual cause of the problem. And the cause of the problem is the structural change that's happened.
And then, so when and I know there was a study that came out recently that was looking at, I can't remember, it was talking about structure, function, and pain and their relationship, how, when people are better, they can have tendons that don't look very good and they can be pain-free and they can fully function. Do you think that's just a matter of that person being able to, or the part around the area that, or the part around the hole has just gotten to a point where it is able to support them what they want to do, and they probably haven't reached that threshold yet where it does matter as much?
Yeah, so basically, if you've got say 60% of your tissue is totally healthy, and you make that tissue great and strong, you can reinforce those structures so that you don't feel much from the other bits that aren't healthy. But then, as I told you, I can immobilize you for 3 days and you lose 20% of your collagen. I can have you go through a period where you have a chest infection, you can't run, you can't do your activities, and now you're going to go backwards. And your tendons are going to not be as strong anymore. Now you're going to go back again, and now you're going to have the same structure, but now that 60% strong stuff is now going to be a lot weaker. And so now the contribution of that other part that's injured is going to be much stronger. So you're going to feel the same, even though the tendinopathic part hasn't changed, it's going to feel a lot more because the structure that's been shielding it has been impaired.
I reckon we're going to have a lot of challenge biases listening in on this podcast because, as you know, Jill Cook and Ebony Rio and Peter Maliaris, the main sort of tendon researchers in Australia, have some of the lectures that they have delivered have in some ways sort of spoken a little bit differently to some of the things that we've spoken about with you. So it's really cool to hear your opinion. I really appreciate it. It's a different perspective, and I think it's refreshing.
And look, Jill and Ebony do absolutely wonderful work. And the thing that's different between what they do and what I do is they do clinical work, and I do basic science to try and understand the basic problem. So when you're looking at clinical work, your primary outcome measure is pain. So they can eliminate pain by treating the donut. And it works really well. And Ebony does beautiful work with central inhibition. If you overcome the central inhibition, you get more load through it. All of that work is amazing. And it works clinically when you can keep the donut strong. You're not going to have tendinopathy. Pain is going to go down. That's the win for them. The issue is that as soon as something happens where the strength of the donut goes down because of a transient whatever, you're in bed, you do whatever happens, you just get busy and you can't load anymore. All of those things are now going to make it so that the strength of the donut comes down, the relative impact of the whole is going to go up. Until you treat the whole, you're not going to. Yes, they can fix the pain, absolutely. They're wonderful at it. They can do that far better than I can. What we are trying to do is understand the signals that the cells are getting and how giving the same cells different signals results in different phenotypes within the tissue. So I can give the same cells a compressive load and turn them into cartilage. I can give the same cells a tensional load and turn them into tendon. I know that if I load a central core patellar tendinopathy with a dynamic load, I'm going to get compression. It just has to happen, because if you ever used one of those finger traps where you put your fingers in and you try and pull them out, they squeeze your fingers in, you can't get them out. That's what happens when you're doing central core patellar tendinopathy. As you stretch, what happens is the material has to lengthen, and as it lengthens, it has to squeeze. And as it squeezes, it's going to compress your fingers. or compress the hole in your knee. If you're doing dynamic loading, that's what's going to happen. So what you have to do is you have to load the finger trap differently if you want to get your fingers out. And it's the same principle here. So I know because of the cell-based work that I do, because of the model-based work that I do, that until you get the right load through that tissue, you're not going to fix the tissue. That doesn't mean that you can't stop the pain. Jill and Ebony stop the pain. They're wonderful at it. But they're stopping the pain in a period of time where you're doing really well. You can keep that going for a while. Something's going to happen. Life is going to happen. Things are going to deteriorate a little bit, and then the pain's going to come back. It's not that the pain wasn't, or the damage wasn't always there. It's just that you had compensated sufficiently to protect it. What I'm saying is that if you get the right load through that tissue, you can actually fix it to the point where when you go through those life issues, it doesn't come back because it's still fixed.
I guess there's no reason why I can't do both. I mean, that they both tie in like well together anyways. So
absolutely.
Yeah.
I have no problem with all of the wonderful work that they've done. I'm not saying that it's wrong. I'm not saying anything like that. I'm saying we're looking at two different things.
Yeah.
They're looking at how to decrease pain. I'm looking at how to regenerate a tendon. They're two vastly different things. If you're a clinician, you care about pain. And that's really why they focus on that structural change that they're trying to get. And that's wonderful. And it's very effective. What we're doing is we're trying to see whether we can actually do these things to fix the tissue.
Yeah.
And there, we're having really good success fixing the tissue. It doesn't mean that you can't do both. It just means that they're somewhat different in what the approach is.
I mean, it's very important for long-term management anyways to be focusing in on that, because it happens frequently where you see patients and myself even, I've had a long history of a hamstring tendinopathy, and I know for sure that if I've had a period of time off loading it, or not going into the gym, or even just going on a holiday, as soon as I come back and try and run or do something again, I'm well aware of it straight away. And we see that frequently with patients where, you know, they have a little bit of a rest, or they go away and they try and come back to their meaningful activity, and all of a sudden they've flared up again. So I'm really
because you haven't fixed the underlying problem.
Yeah. I'm really looking forward to trialing what you've recommended and seeing how that plays out. Yeah.
Every morning when we have our coffee in the morning, I'm just going to grab Kelly's leg and go contract, and for dinner every night the rest of my life.
Yeah, you don't have to do it again. It's once you get it, once you fix the issue, then you don't need to do it all the time. It's just a matter of getting the tissue back to the point where it's able to handle the loads that it's placed under. And that's one of the things that we don't do effectively, and that's why the number of repeat hamstring pulls is huge, because we get them back to where they can get back on the field and play, but we haven't fixed the underlying problem.
So talking about, changes in the tendon, and something that's, from the research that I've read, and we work with dietitians, there seems to be conflicting studies coming out about collagen supplementation and tendons. What have you seen? And I've heard you speak about this on other podcasts, talking about kids with growth plate issues, like we see severs and things like that, and any kind of Osgood-Schlatters and things like that. Like, what's the relationship there? And people with tendinopathy, like, are you seeing in your models that collagen supplementation or other specific supplements are really helping with the regenerative part of the tendinopathy, or any kind of soft tissue?
Yeah, so the issue with collagen supplementation, so we had shown a long time ago with Greg Shaw down at the Australian Institute of Sport that if we supplement people with collagen, we can increase collagen synthesis. One of the things that is problematic is when you talk about it, and you guys know this as physical therapists, you're going to talk about, look, it's all about loadings. Everything's about load. Loading's hard. Exercise is hard. So people are like, yeah, but isn't there some injection I can take? Isn't there something simple I can do? So they're going to focus on, collagen. That's going to make it. Okay, it might play a small role. And it does play a small role. And we know, for example, there's really good meta-analysis on collagen supplementation with osteoarthritis in the knee, where it actually improves osteoarthritis in the knee. But this isn't happening over a day, week, month. This is happening over months to years. Okay. The same thing that everybody says, oh, it's all about protein, so I'm going to eat lots of protein to build my muscles. No, if you eat as much protein as you want and you sit on your ass and don't do anything, you're not going to get big muscles. It is not about the protein that makes your muscles big. It is about doing some resistance exercise. You're going to get a stimulus to grow your muscles. If you do that, then having protein present is going to give you a little bit of a boost. Same thing is true for collagen. If you're doing the loading right, and if you're getting the right stimulus through the cells, having collagen nutritionally there to provide substrate, to provide glycine, to provide proline, to provide signals potentially, that's going to now give us something that is going to contribute a small amount to making that tissue better. But if I don't get the load right, collagen's not going to do anything. So the core thing that's most important is that any nutrition that we do supports the loading that we do. I can eat as much protein as I want. If I don't get out of bed, I'm still going to lose muscle mass. There's nothing about protein. There's no way that you can take protein and not lose muscle mass if you're immobilized. It just doesn't happen. Okay? Same thing is going to be true for dietary collagen. If I don't get my loading right, there's not going to be any benefit of dietary collagen. If I do get my loading right and I've got some dietary collagen, there's going to be a small effect of that. We don't know exactly what percentage that effect is, but there seems to be a small effect. And if we have a bigger dose in a short period of time, we might be able to see the effect easier. So there's a group out of England that's just published a study looking at 30 versus 15 grams of collagen when they do heavy squat. The 30 grams gives you a bigger collagen synthesis response than the 15 grams. But again, heavy squat, that's the component where you've got this big load. The big load, small effect of the dietary collagen, big effect of the exercise. Same thing that's true for your muscle. Leucine-rich protein, wonderful. But if you don't do the loading, leucine-rich protein is no better than anything else. Okay, so people focus on the collagen because it's easy. Because I can put it in my coffee, I can do it totally good. And it's going to have it has a place. We know that it has this effect on cartilage in the knee, decreasing osteoarthritis. Do I take it? Absolutely. And do I see a difference with it? Yes, but I don't see a difference like, oh, yesterday I didn't get it, so today I'm going to get it. Oh, now I feel better. No, it's that I've taken it over a long period of time. I take it from a source that is a fish-based or a skin-based source, so there's no heavy metals in it. And I take it at the same period of time every day, since collagen synthesis is regulated in a circadian way, and it usually peaks about 24 hours after my exercise. So I'm pretty consistent in when I take it. A lot of these things that people don't consider when they do collagen supplementation are actually pretty important with it. And so, yes, does it have an effect? We think it has a small effect. But that's also why I'm here in Holland, because those hamstrings we're getting out, half of them have had dietary collagen, and half of them haven't for 7 days. And we're going to measure collagen turnover in the human hamstring as a function of dietary collagen intake.
Yes, you're right, definitely, with the amount of studies that are coming out saying that movement is important, and movement, offers all these great benefits. It's just having people be able to do that and engage with that consistently. What issues do you see? And I've heard this, heard you speak about this on other podcasts as well, talking about hormonal changes and how that can affect tendons and ligaments. Probably the last couple of years, we've had some female researchers come on, both sports dietitians and other people, talk about how, training around, say, your menstrual cycle, or how ligaments and tendons may behave differently for males and females, and estrogen plays a big part in that. Do you see these changes when you have estrogen or do you see changes in tendons and ligaments, and how does that affect kind of males and females? And the same would be said with testosterone as well.
Sure. So I had a really good PhD student, Nkechi Chidi-Ogbolu, and what she did was some simple studies where she looked at the effects of estrogen and testosterone. And then she also did a study where she basically tried to mimic what would happen in older women who are postmenopausal, where they're getting aromatase inhibitors. So the idea here is that estrogen and testosterone, what her research shows is it is something that we all kind of know. Testosterone increases tendon and ligament stiffness. Estrogen decreases it. So Schultz has done a bunch of studies where she pulls on the knee of women and men over a 30-day period. And the women, there's an increase in knee laxity as you get around ovulation, and the men, no change in knee laxity through the cycle. Wojcic's study, where he looked at ACL incidence in women over the cycle, saw that around ovulation there were more ACL ruptures than when there weren't around ovulation. And again, we've done a study where we use a device to pull on the knee. We see anywhere between a 1 to 3 millimeter increase in knee laxity in women at ovulation versus at menstruation. Okay, so we then used our engineered ligaments, treated them with low estrogen, and then for 48 hours we treated them with physiological levels of high estrogen. So what would happen around a luteal surge? Stiffness of the ligaments went down, collagen content stayed the same, which meant that the cross-linking was probably decreased. When we then looked at the cross-linking enzyme lysyl oxidase, its activity is directly inhibited by estrogen. So estrogen directly inhibits lysyl oxidase activity. So that means the enzyme that cross-links collagen is inhibited by estrogen. Makes sense evolutionarily, because laxity in ligaments is going to be very important for childbirth. And so if you have a cyclic increase and decrease in that, so that you are maintaining a little bit more laxity through your life, what's going to happen is that's going to make it easier for childbirth. When we look at performance measures, we know that women are 4 to 8 times more likely to rupture an ACL. Stiffness of the ACL is going down around that luteal phase. They're 80% less likely to pull a muscle. Muscle pulls happen when the tendon is stiffer than the muscle is strong. Both of those things are happening because of tendon stiffness. If you go beyond tendon and look at blood pressure, women have a lower blood pressure than men. Why? Because our blood vessels have collagen in them. Women's blood vessels with estrogen in them expand and relax more than men's blood vessels where the testosterone is helping to cross-link the collagen. So the collagen in the tendons are stiffer, the collagen in the aorta is stiffer. The result is I have higher blood pressure than my wife, because again, there's stiffness in that collagen matrix that is regulated by estrogen and testosterone. So it's not about estrogen alone, it's about estrogen and testosterone. And the interesting thing is that when you actually have an aromatase inhibitor, and this is a drug that prevents you from synthesizing estrogen from testosterone, the effects on tendons and ligaments are dramatically different. So one of the things that we see in women who have estrogen receptor positive breast cancer, and they get treated with aromatase inhibitors, is they have tendinopathies, and they have lots of joint pain and lots of tendon pain. And what we find in our research is that the testosterone increases stiffness, estrogen decreases stiffness. But when we treat with testosterone together with the estrogen or the aromatase inhibitor, what we see now is that instead of increasing stiffness, the stiffness drops really precipitously. And so what we're seeing is that in that situation where you've got a postmenopausal woman where testosterone tends to be high, you give her an aromatase inhibitor to prevent the breast cancer, what's happening is her tendons are actually getting the signal to become much, much weaker. And so you see these hormonal differences in people that drive a lot of the performance effects. Because if I want to increase your rate of force development, I want to increase your connective tissue stiffness, I want to increase your cross-linking. Men have a greater rate of force development than women. Already they have an advantage because that higher testosterone has increased the cross-linking of the tendon. So that's one of the performance measures, but it also affects my tendons. So my likelihood of a muscle pull is higher. It affects my ligaments because my ligaments are strong or stiffer. I get less joint movement. I get fewer ACL ruptures. So a lot of the performance, and again, I also have higher blood pressure because my aorta has got collagen in it. It's supposed to stretch and recoil, but because my testosterone has cross-linked the collagen, made it stiffer, it doesn't stretch as easily as my wife's. So all of those things together give me a lot of different effects throughout the physiology of the body that come back to this collagen regulation of the cross-linking and of the matrix stiffness. And so, yes, we see that women have less stiff tendons. On average, they're more flexible than men, less stiff tendons. On average, they have greater knee laxity, and that knee laxity tends to increase at ovulation, and it tends to be lower at menstruation. So all of these things can be traced back to this lysyl oxidase, this cross-linking component of how we're dynamically changing cross-linking within the tendon. And yes, it does have implications for training, but it also has, bigger implications across the board.
So over the course of life between childbearing, post-childbearing, perimenopause, postmenopause, there were like pretty dramatic changes happening over that course. Whereas it seems for men it's more consistent. For males, it's more consistent. Without as many peaks and ebbs and flows.
But again, remember, one of the things that we can do is I can take you and I can change your testosterone levels within 30 minutes. I can have that effect. That's one of the things that we see in athletes all the time. When an athlete is on a tear and they're doing great, yeah, their testosterone is going up because everybody's treating them like godlike. And so they get this, there's a physiological increase in testosterone. I can double your testosterone levels by having a beautiful person that you're super attracted to start talking to you and be really attentive to you. Your testosterone levels will rise, will double within a 30-minute time period.
That's Kelly to me every night.
There you go.
Set me out with an alley-oop there. That'll save me for the week.
I can also have the reverse. If I'm a coach and I yell at you in front of all of your teammates and I tell you that you're your testosterone can drop 2 to 4-fold. So I can manipulate those things throughout a cycle very easily, and that's going to have physiological ramifications. So it's not surprising when an athlete is having a really bad go of it, a male athlete is having a really bad go of it, their testosterone levels are going down, their performance is going down as well. It actually goes very naturally, physiologically together. Yeah. So you do see those. It's biggest in women, and it's, again, you bring in estrogen replacement in older women who are postmenopausal. And again, Jill Cook did a beautiful study where she looked at runners who were either used estrogen replacement or didn't. The ones who used estrogen replacement had smaller Achilles tendons than the ones who didn't. So you can manipulate all of these different things, and it happens. Mette Hansen has wonderful research on this. She's now in Aarhus in Denmark, and she's taken young women and have them do exercise, and she's taking postmenopausal women and have them do exercise. The collagen responses are exactly opposite.
Wow. So
you can see dramatic differences in what happens within the body based on what hormones are circulating and what's all circulating within the system.
And it's logical to think of injury risk and performance and things as well, as a result of that.
So cool.
Absolutely.
Yes. Keith, thank you so much for coming on. That was thrilling, to say the least.
That was great. I feel like it's just so cool to hear what you've had to say. We've as we said, we've referenced you quite a lot over previous podcast episodes, so it's so great to hear those words all coming from you, and I think it's going to help everyone get a really nice, well-rounded idea and understanding on tendons, because I do think it really elaborates on a lot of the knowledge that we do have, because it just takes it that step further in a way that I haven't been able to understand of yet. So thank you.
Yeah, absolutely. You're welcome.
Yeah. Do Keith, Kelly usually clocks off about 6 p.m. She gets up at like 5 a.m. After 6 p.m., the lights are off, barely get a word out of her. I've never seen her ask questions, be this engaged before at this time of the night, ever in
Yeah.
our whole life. We've been together 5 years. So I just need to start talking about tendons more at dinner and I'll be in.
There you
I'll be
go.
able to do well.
Not a bad thing.
Yeah. All right. Thank you, mate.
Absolutely. Good luck.